So today's talk is going to be on stage D heart failure, which is refractory heart failure, and what clinical or objective evidence are there to suggest refractory heart failure. So some clue in our assessment that will help us to determine the patients who have stage D heart failure or refractory heart failure. If the ejection fraction is less than 30%, that's a suggestion. Ejection fraction less than 30% by itself does not class someone as refractory heart failure. Some of these patients will have what we call a pseudo-normal or restrictive mitral inflow pattern. As you recall, the normal mitral inflow pattern is one where the E velocity is greater than the A velocity, that's the mitral inflow. When we say pseudo-normal, the E is greater than the A velocity, but it's an abnormal situation. And then restrictive mitral inflow is when the E to A ratio is greater than 2. Other tip-off for refractory heart failure is when the pulmonary capillary wedge pressure. So this is when we do a right heart catheterization, and we find that the pulmonary capillary wedge pressure is greater than 16 millimeters mercury, or the right atrial pressure is greater than 12. And then the patient will also have a high BNP, brain natriuretic peptide, or NT-proBNP level in the absence of non-cardiac causes. So these are the supportive evidence of refractory heart failure. So, you know, it's not one thing that's going to define these patients. But so if we look at the definition, it's a subset of patients with chronic heart failure that continue to progress. They continue to get sick, and they develop severe symptoms despite continued maximum guideline medical therapy. And we describe some of these patients as end-stage heart failure or refractory heart failure. Okay? The 2009 American College of Cardiology Foundation and the American Heart Association guideline, you know, look at patients and say, you know, you have to really determine if these patients are truly refractory. So you have to analyze them properly and make a determination, are these patients truly refractory? Because if they're refractory, then they're eligible for certain specialized advanced strategies, and they should be referred to institutions that they can get these advanced therapy. And one such advanced treatment is the mechanical circulatory support, which essentially is a group of device therapy that helps the heart. It helps the heart, so it facilitates fluid removal, it enhances in-organ perfusion, and patients will feel better. A lot of these patients gonna need continuous inotropic infusion or inotropic infusion. And what we mean by that, when we say inotropic, we mean something that increases the contractility of the heart. So they will need intravenous inotropic medication. If that therapy don't help, the definite treatment for these patients is cardiac transplantation. That approach is changing over time, and the reason for that is we don't have enough hearts. So because we don't have enough hearts to give all these patients who require heart transplantation, we develop different techniques to assist the heart. And we look at those. One of those is the LVAD, because the LVAD was really designed as a bridge to cardiac transplantation. But the current generation, even the previous generation, did so well, and we can treat patients long term on these. And then we also have to deal with end of life issues, because some patients, the pump is damaged to such a point that, and especially if they're older and stuff like that, we have to discuss end of life care, hospice care. So the European Society of Cardiology, they came up with a series of clinical scenarios that would define advanced heart failure. So what the European Society of Cardiology says is, if the patient has severe symptoms of heart failure with shortness of breath and or fatigue at rest, or with minimal exertion, um, the so-called New York Heart Association class 3 or 4. So these are really symptomatic patients. Okay, so severe symptoms of heart failure, and we usually talk about shortness of breath and fatigue as well, either at rest or minimal exertion. That would put them in a New York Heart Association class 3 or 4. So the European Society of Cardiology recognize that these patients have advanced heart failure. If they have episodes of fluid retention, that may manifest itself as pulmonary and or systemic congestion, peripheral edema, and or reduced cardiac output at rest, and peripheral hyperperfusion. So any type of fluid retention. So these are evidence of advanced heart failure. And as we mentioned before, if the ejection fraction is less than 30%, they have the pseudonormal or restrictive mitral inflow, elevated pulmonary capillary wedge pressure, or right atrial pressure. Remember when we said that one of the most accurate means of assessing fluid retention is elevated right atrial pressure, or the jugular venous pressure, and then a high BNP or NT-proBNP. The inability of these patients to exercise, so that means they can't do any type of exercise, okay? When we look at the 6-minute walk distance, in 6 minutes, they walk less than 300 meters. They can only walk, less than 300 meters in 6 minutes. And this is an objective assessment. And then when we look at the peak oxygen consumption, is less than 12 to 14 mils per kilogram per minute. And then in history, they'll have more than one or more heart failure hospitalization in the last 6 months. So remember, this is the European Society of Cardiology assessment of advanced heart failure. And then they look at the presence of all previous feature despised attempts to optimize therapy. You're going to give them the guideline directed medical therapy, and if they fail that, then you can consider CRT, which is the resynchronization therapy that we spoke about. So that's the European Society of Cardiology. I don't want to say definition, but those compilation of symptomatic and objective data help them to assess patients with advanced heart failure. So clinical events and finding useful to identify patients with advanced heart failure. So we're talking about patients with stage D advanced heart failure. these patients usually have repeated that 2 or more hospitalization or emergency department visit in the past year, or they may have progressive deterioration in renal function because of decreased renal perfusion. They get an increase in lipids and creatinine. They will have weight loss, and we'll call that cardiac cachexia. Intolerance to the ACE inhibitor due to hypotension or worsening renal function. And there are also intolerance of beta blocker because of worsening heart failure or hypotension. When you check the vital signs, you'll see that the blood pressure frequently is less than 90 millimeters mercury. They'll have persistent shortness of breath, even with minimal activities such as dressing or bathing. When they get in, they doing regular activities, they get significant shortness of breath. These patients' inability to walk 1 block on the level due to shortness of breath or fatigue, and they will have low serum sodium, so the serum sodium will be less than 130. If they have an ICD-10, they will have frequent ICD shocks. So these are things that will let you know that the patient is now developing advanced heart failure or refractory heart failure. The Interagency Registry for Mechanically Assisted Circulatory Support, the so-called INTERMACS, developed 7 profiles that further stratify patients with heart failure, with advanced heart failure. So we usually refer to the INTERMACS. So this is the 7 profile that help to stratify these patients with advanced heart failure. And the first one that we look at is what we call critical cardiogenic shock, or the so-called crash and burn. So these are life-threatening hypotension. So the patients with chronic heart failure, now they develop life-threatening hypotension, low blood pressure, and rapidly escalating. They require increased dose of inotropic drugs. These are drugs that increase contractility or increase blood pressure. So they are now requiring more of these, higher doses of these medications. And then when you check, they have critical organ hypoperfusion, namely the kidney. They're not perfusing the kidney, so they will develop kidney failure, worsening acidosis, and elevated lactate levels. And then number 2 is what we call the progressive decline, the so-called slide fast on inotropes. So these patients are dependent on inotropic support. That again, they are dependent on medication to increase contractility of the heart. But nonetheless, they show signs of continuing deterioration, even though they're dependent, they increased dose of inotropes, they're still deteriorating, worsening renal function. They have fluid retention and other major status indicated. So these patients, you cannot take off their inotropic medicine. They're sort of dependent on it. Okay, so this is your INTERMACS 2 and your INTERMACS 3. These are stable, but they're inotrope dependent as well. So they're clinically stable on mild to moderate doses of intravenous inotropes. And again, these patients, you can't take them off. You can't take them off. They will develop worsening symptoms and progressive organ dysfunction. And then the number 4, INTERMACS 4, resting symptoms and oral therapy at home. So these are patients who they're on oral medicine, but they have symptoms of congestion at rest, or minimal activities such as activities of daily living, such as just dressing or bathing. They become shortness of breath. Okay, so they are very symptomatic. They have significant leg edema and probably ascites, and then the Intermax 5. So you don't have to memorize these. If you're treating advanced heart failure patients, you can pull out your Intermax and look at, you know, what class the patient or what profile the patient should get. And then your Intermax 5, exertion intolerant. These are patients who are housebound. Patient is comfortable at rest, so when they're not doing anything, they're fine, but they're unable to engage in any activity. They're living predominantly within the house, and we say that they're housebound. And then the Intermax 6, exertion limited, we refer to them as walking wounded. This is a patient who is comfortable at rest without evidence of fluid overload, but who is able to do some mild activities of daily living are comfortable, and minor activity outside the home, such as visiting friends or going to the restaurant. But they're fatigued within doing, you know, a few minutes of doing anything. So they're comfortable at rest, but they just can't do anything because they become very fatigued. So this is Intermax 6, and then Intermax 7. You know, this is the Advanced New York Heart Association Class 3. This is patient who is clinically stable with a reasonable level of comfortable activity, despite the history of previous decompensation. It may not be recent. These patients are usually able to walk more than a block. Decompensation, they require intravenous diuretic or hospitalization with a previous one. So this is Intermax. So we usually refer to these profiles when we're taking care of these patients. And again, it's not something for you to memorize. You can always, you know, in any advanced heart failure unit, they'll have these Intermax profiles. So when we get a stage D, so-called refractory heart failure patient, we have to really, you know, is the patient really refractory? Are we making the correct diagnosis? Because the patient may have chronic heart failure and they develop urinary tract infection and they decompensate. So it's not really refractory. So we have to sit down and really analyze what's going on and make sure we come up with the correct diagnosis. Because they may have a remediable etiology for their decompensation. You know, they may develop hyperthyroidism on top of the chronic heart failure, and then they decompensate. So you always have to look for alternative explanation and don't quickly put the patient in a class D, stage D heart failure. Again, alternative explanation for decompensation may be shortness of breath due to pulmonary disorder. The patient may develop COPD or they may develop a pneumonia. And if they have cachexia, it may not be cardiac cachexia, it may be weight loss due to some other cause. So you have to, again, if they develop hyperthyroidism, they may develop weight loss due to that. Okay, so you have to carefully assess the situation and make sure you're dealing with a stage D heart failure patient. What about water restriction? And this is very important. Water fluid restriction gets only a class 2A indication. It is not a class 1. And because when you're treating patients with refractory heart failure, you don't want to dehydrate them. And that is why, you know, you're not going to routinely restrict the fluids. But fluid restriction between 1.5 to 2 liters per day is reasonable in stage D heart failure patient, especially in patients with hyponatremia. So one of the things that will tip you off that these patients should be fluid restricted is if they have hyponatremia, serum sodium of 130, 129. More than likely should fluid restrict them to reduce congestive symptoms. Again, it's crucial to weigh these patients. So you have to weigh the patient and you have to monitor symptoms. And when they're home, they should be on some weight and symptom monitoring program. You can, you know, some some institution have specialized scale, and they will, follow the patients with symptoms. They'll report any symptoms, shortness of breath, fatigue, that type of things. So, as mentioned, routine fluid restriction does not appear to result in significant benefit, especially if the patient is refractory, because if you restrict the fluid too much, they can develop renal compromise and decompensate. However, limiting fluid intake to 2 liters per day, especially in conjunction with sodium restriction, enhances volume removal in diuretics. So in order to maximize the effects of diuretics, you should do some fluid restriction along with salt restriction as well. And again, as we said, if the patient is hyponatremic, low sodium, fluid restriction will help that scenario. In very hot and humid climates such as the Caribbean, you have to be very, very careful, because if you do excessive fluid restriction, the patient can become very dehydrated, and you can predispose them to heat stroke. So you have to be very careful, especially in that type of environment. In the United States in the summer, you have to be very careful. A low sodium is primarily due to the inability to excrete free water. The patients hold on to the water and dilutes the sodium. So when you assess the serum sodium, it's low. Now we're going to move on to inotropic support. So when we say inotropic, these are medication that alter the force or the energy of muscular contraction of the heart. So it's either going to increase the contractility of the heart muscle, or it's going to decrease the contractility of the heart muscle. When we say positively inotropic agents, are, it's going to increase the strength of contraction. Okay, so positively inotropic agent increase the strength of the contraction, whereas negatively inotropic agent decrease the strength of contraction. And we use this quite a bit in patients with refractory heart failure, stage D heart failure. So what are some of the recommendations? The class 1. So a class 1 recommendation for inotropic support is until definitive therapy or resolution of the acute precipitating problem occurs. So the patient have chronic systolic heart failure, ejection fraction is low, and the patient is acutely sick. We can use inotropic medication until we come up with some definitive therapy. If the patient has multiple blockages, so they have multiple coronary artery blocks, we can institute inotropic support, take them to the cath lab, do angiogram, and then we can revascularize them either with stents or bypass surgery. Or we can use the mechanical circulator support that we mentioned, and then and then heart transplantation if they're a candidate. So that's one of the use for inotropic support. It gets a class 1 indication. Again, these patients are in what we call cardiogenic shock. Okay, so when we talk about cardiogenic shock, they have low cardiac output. The systolic blood pressure is usually less than 90 millimeters mercury, and their extremities are usually very cold and clammy because of the low cardiac output. So we give them inotropic support to improve systemic perfusion and preserve end organ performance. So that's class 1 indication. Okay, so I'm not going to belabor class 2, but once the patient is refractory stage D heart failure, I mean, you max out and your guideline directed medical therapy, so they're going to get the beta blockers, they're going to be on the ACE inhibitors, they're going to be on the aldactone, and they may be also on device therapy that we spoke about in stage C heart failure. They may have the ICD and they may have the cardiac resynchronized therapy and the BiV pacemaker, but they're still very symptomatic. You can do your inotropic support. These are medication that increase contractility of the heart, and you can wait the mechanical circulator support. These patients should be in centers that can do the mechanical circulator support. Okay, and the definitive therapy would be cardiac transplantation. And of course, you can give the inotropic support short term or long term. We prefer short term because long term inotropic support is associated with adverse outcome. So you want to do short term, stabilize the patient, and then you can do your definitive therapy. But long term usually is associated with problems. And so long term, even though sometimes we have to give long term inotropic therapy or support, these patients don't do well. And we usually reserve this for palliative care. So if we can't do anything more for the patient, then we can give them long-term inotropic support, make the patient comfortable, because long-term therapy is associated with harm. It's going to harm the patient in the long run. So we can't say that is a long-term strategy. So it can't be a long-term strategy because it's going to harm the patient. Patients don't do well. So when we talk about inotropic support, inotropic agents, these patients should be in the hospital, and we should document severe systolic dysfunction. So the ejection fraction 20% or less than 20%. A lot of these patients have low blood pressure and evidence of impaired organ perfusion. So, decreased cardiac output, kidney compromise, and they'll have evidence of, they may have evidence of congestion or not, but these patients are very sick. What we know is that inotropic agents or inotropic support improve hemodynamic compromise. It helps, it will increase cardiac output, it will increase organ perfusion, so it does a lot of good stuff. And it should be given to patients who have refractory heart failure, stage D. So the patients are on the guideline-directed medical therapy. They're maxed out on the recommended therapy, and they're not improving. So we give this strategy because we can now increase cardiac output, increase end organ perfusion, and of course we always talk about the kidneys and the brain. So those organs have to be perfused. So the agents that are currently in use, we have the adrenergic agonists. So these are medicines, they will increase the adrenergic response. So the one that we use is dopamine. And dopamine, we can use different dose of the dopamine. And in order to increase cardiac output, you have to use higher dose. The lower dose of dopamine, we usually talk about a renal perfusion dose. You do get some increase in cardiac output, you get increase in heart rate, and you get to decrease in the systemic vascular resistance. The peripheral vascular resistance will not be affected too much. So
చచ్చిపోతే ధ్యానం లేకుండా
So, all right. Okay, so dopamine. So again, you can start with a small dose, but this is what we usually refer to as the renal dose, 2.5 to 5 micrograms per kilogram per minute. Um, but if the patient is very symptomatic, you might have to increase it up to 10 to 15 micrograms per kilogram per minute, increase cardiac output. The problem with dopamine, though, it's going to increase the heart rate. And it might increase the systemic vascular resistance a little bit too much, so you have to be careful. The other inotropic agent that we use, that we can use is dopamine. So just give me 1 second. Okay, so dobutamine is one of the more common inotropic agent that we use. And the dose is about 5 to 20 micrograms per kilogram per minute. Those of you who do echo, we use dobutamine for our dobutamine stress test, but we use it in heart failure to increase contractility, and dobutamine is one of the mainstay. It's one of the mainstay in our stage D heart failure. It also increased cardiac output, increased the heart rate, but it does not affect the systemic vascular resistance or the pulmonary vascular resistance too much. Okay, and it's also one of the adrenergic agent. So that's dobutamine. Milrinone, I'm not sure if this projects very well, but milrinone is a phosphodiesterase inhibitor. Okay, phosphodiesterase inhibitor, inotropic agent. So it inhibits phosphodiesterase and increase cyclic AMP, and as a result will increase contractility. So the dose is 0.125 to 0.75 micrograms per kilogram. So again, it's going to increase the cardiac output, increase the heart rate, and you actually get the decrease in the systemic vascular resistance and peripheral vascular resistance. So that's our inotropic agent. So, there are three of them we mainly use. Now, our mechanical circulator support, which is, available in advanced heart failure center, and we're using these devices more and more. It has a class 2A indication, however. So mechanical circulator support is beneficial in carefully selected patients with stage D heart failure with reduced ejection fraction, so they have to have a low ejection fraction, in whom definitive management, such as cardiac transplantation or cardiac recovery, is anticipated or planned. So you have to have a strategy. Are you going to use your mechanical circulator support and then you're going to do bypass surgery, or you're going to put in a stent, or you're going to repair something in the heart? So you have to have a strategy. You have to plan what you're going to do. So these devices improve hemodynamic parameters. So it's not uncommon for someone to come to the hospital, ejection fraction less than 20%, and they're very symptomatic. You want to get them over that little hump, because they may just have an infection which sort of decompensate them, or the patient may have a pulmonary embolus, which decomposes. So you want to bridge them over this little acute event. So the timely use can prevent multi-organ dysfunction and death, because if you do not intervene, then they will develop progressive multi-organ dysfunction, and they will succumb. So you have to support them. The different type of mechanical circulatory support devices that we have: the intra-aortic balloon pump, and we'll give you a brief description of this device. We have the impeller, the tandem heart, and the extracorporeal, the so-called ECMO, which is the extracorporeal membrane oxygenation. So in a nutshell, the intra-aortic balloon, so this is our iliacs, this is the aorta, the descending aorta would come, the aortic arch, and the ascending aorta is right there. What we do, we have a balloon, so we insert a catheter. There's a balloon on the catheter, different volume, and this balloon is time dependent on what the heart is doing. And we have a setup where when the heart contracts, so when the heart contracts and push blood out, the balloon is deflated. When the heart relaxes, now the balloon is inflated. And when the balloon inflates, it's going to push blood backwards, and that will increase coronary perfusion. So when the heart contracts, the balloon deflates, and by deflating, it's going to reduce the systemic vascular resistance. So the intra-aortic balloon pump does a lot of good things. It reduces the systemic vascular resistance, it increases coronary perfusion, and will increase cardiac output to some extent. So we use this if we have a patient who have, say, significant coronary artery disease, a left main coronary artery disease, and the patient is decompensating, and we need to take the patient to the cath lab, do a quick procedure, open the blood vessel. Intra-aortic balloon pump is fairly is good in that scenario, and there are other indications for that. Impeller, basically, so we have someone ejection fraction less than 20%. The left ventricle cannot pump the blood out. Ejection fraction less than 20%, the left ventricle cannot pump the blood out. What we do, we do a catheter procedure. We insert a catheter into the femoral artery, into the iliac, up to the aorta, and then we come straight up across the arch. We cross the aortic valve, and we put the catheter in the left ventricle. So the catheter is in the left ventricle, and what we do, since the left ventricle cannot pump the blood out, we suck blood out. So we suck the blood out through the catheter, and the blood goes into to the ascending aorta. So essentially, this is a very quick procedure. Patient is decompensated, ejection fraction maybe less than 20%, and the patient very symptomatic. We can quickly insert this catheter into the heart, suck the blood out into the ascending aorta, so the patient will do better. And then this is the tandem heart, which is another mechanical circulatory assist device. So we have a catheter in the femoral vein, and we go up to the inferior vena cava. We go to the right side of the heart. We puncture the atrial septum, and we put the catheter in the left atrium. So the catheter is in the left atrium, and the catheter is going to suck the blood out of the left atrium, and we can put the blood in the femoral artery. So we essentially just assisting, because the left ventricle cannot pump the blood out. So we're going to collect blood from the left atrium, and then put it in the femoral artery. So that this is the tandem heart, and then the ECMO um, is basically extracorporeal membrane oxygenation. So this is mean, you know, if the patient lungs and to some extent the heart is not functioning. So if the patient lungs is not functioning for whatever reason, we can just take the the deoxygenated blood. So we can take the blood that would go into the right atrium. We take that blood and we pump it through an oxygenator. So instead of going to the lungs, the blood is now going to go to this oxygenator, and it's going to get is going to be oxygenated. So remember, the function of the lungs is just to oxygenate the blood. So we can divert that blood into this oxygenator, which is going to oxygenate the blood, and then we can put it back into the circulation. So this is the ECMO. All right. So these mechanical circulators support their viable therapeutic option for patients with advanced stage D heart failure. Of course, these patients are usually on guideline-directed medical therapy, and they will have cardiac device interventions such as defibrillator, CRT. Then we have the ventricular assist devices, the VADs. So these are ventricular assist devices. They're going to assist the ventricle. So remember, the ventricle cannot pump the blood out, so we can assist the ventricle. And it's not anything fancy. We just assist the ventricle because the ventricle cannot pump the blood out. We can have a VAD in the left ventricle, that we call that a left ventricle assist device, or we can have it in the right ventricle assist device, or you can have it in both. So it looks like that. So we would, in the apex of the heart, we'll have a tube inserted right there, and then we have a pump mechanism here, and we're going to pump the blood. We're going to suck the blood out from the ventricle. Remember, the ventricle cannot pump the blood out, so we're going to essentially suck the blood out from the ventricle, and then we're going to pump it in the ascending aorta. So we have a tube connected to the ascending aorta, and we have our pump mechanism. So when the patient, when we finish our procedure, of course, you have the tube in the left ventricle, your pump mechanism, and the tube going back to the ascending aorta. And then you're going to percutaneously, it's going to be on the outside, and then you have your power. This is going to power the device, okay? And then you can strap onto the patient. So this is what your VAD, this is the LVAD. And so again, the RVAD, right ventricle assist device, is just going to do the same thing for the right ventricle. So when our patient comes to us and they have low cardiac output syndrome, okay, very symptomatic low cardiac output syndrome, despite guideline-directed medical therapy and or ICD or CRT, if the patient have predominantly left ventricular failure, we can try a intra-aortic balloon pump. If that not indicated or it's not helping, then we can do a LVAD. Okay. If both ventricles are failing, then you can do biventricular. You can do a LVAD, RVAD. Or if it's just the right ventricle alone, you can do a RVAD. If you have cardiorespiratory failure, and it's mainly say the lungs not functioning, you can do your ECMO, okay? And again, it depends if the heart is not functioning well, then you can do there are different types of ECMO. You can do a VA ECMO or a VV ECMO. So or what we're trying, some of these patients are going to need cardiac transplantation. So we're doing a mechanical circulator support to get the patient to what we call, this may be destination therapy, which is heart transplantation. Okay. Now, when we do all of this, we do these procedures because we want to transition the patient to definitive management. Again, if the patient just have significant coronary artery disease, we may take them to bypass surgery and they do well. All right. Sometimes we just need time to sort out what's going on. So you do your Impella device, and then you compensate the patient, and then you can decide how you're going to manage the patient long term. But you just want to you want to intervene to prevent further end organ damage, because you don't want the patient to develop um, you know acute cortical necrosis and then develop kidney failure, which is going to compound everything. So quick decision. So yeah, bridge to decision, bridge to recovery. Um, you and most of the time when we do these things is for bridge to transplantation. The patient is on the transplant list. Again, remember, heart is not very common. We don't have a lot of hearts, so that's the limiting factor. So we may want to say we might put the patient on a VAD device until we can get a heart for that patient. Or we talk about a bridge to candidacy. Some patients may not satisfy the transplant criteria. And one of the transplant criteria, they shouldn't have significant pulmonary hypertension. For somehow, when we just do a VAD on these patients, the pulmonary pressures go down. And so you may want to do that. You may want to put an LVAD in, and when the patient, when all the criteria for transplantation are satisfied, so the pulmonary pressures go down, you have some amount of reverse remodeling, and then the patient now become a candidate for transplant. So we talk about a bridge candidacy or destination therapy. Some patients are not candidates for heart transplantation, and we'll do a LVAD, and patients have been on the LVAD for a very extended period of time, and they live a relatively normal life on a LVAD because they're getting the circulatory support that they need. Okay, and the definitive therapy is really cardiac transplantation. But the problem with that is there are criteria that the patient has to satisfy. And not only that, we don't have enough hearts. Okay, so that's one of the problems with cardiac transplantation. All right, so we that is the management of stage D heart failure in a nutshell. Um, each of these therapy have an extensive discussion with it. One of the things that, especially when we do our mechanical circulatory support, one of the important things is to do your pressure volume loops, because what we realize when we do mechanical circulatory support, and if you look at the pressure volume loop, if you remember the pressure volume loops, the area in the area in the loop is basically cardiac work. And when we put in these devices and we look at the pressure volume loops over time, the area gets smaller. So therefore, the amount of work that the heart is doing is getting less. So we use pressure volume loops in to help us to manage these patients. All right, so we're going to stop here, and as promised, so we need to still look at the current. So these are current recommendations, but the recent updates. So there are some updates that we still need to go over. So hopefully we can do that next week. Okay. All right. Good night.